talk about evidence-based healthcare, and it's a very odd thing to be talking about. I mean, what else would you want healthcare to be except evidence-based? And I think we live in rationality and evidence and the scientific method touches every aspect of our lives. So why is it that we are here in 2013 talking about whether evidence is applicable to medicine and how it should be applied to healthcare? What's holding us? Something's holding us back. What is it? What do we need to do and reform here?
Right. Good morning. Evidence-based medicine, in some sense, is mom and apple pie. The alternative is eminence-based medicine. Probably not what we want. But what we need is for evidence-based medicine to be a tool that really drives increasing value for patients. And that means redefining services around how value is created for patients. So value in healthcare depends on improving the health outcomes for individuals based on the medical circumstances that they face. So talking about value means much more than a change in vocabulary. It means thinking about how do we actually drive improvement in outcomes for patients. Right now, professionalism and competition focus more on cost shifting than they do on driving improvement in health outcomes. We need to realign the structure so that care delivery is structured around how value is created for patients rather than on how doctors progress professionally. We need clinically integrated services. So most efforts to look at the outcomes and costs look at the parts and the pieces and the places rather than looking at the whole solution or the whole protocol or the whole continuum of care. And that's a problem. So we want to look at the whole journey, inpatient and outpatient rehab and drugs together. So for example, if you think about pediatric cancer care in the US, almost all the patients are treated under a protocol, whole protocols. So you're comparing protocol A and protocol B. Care for adult cancers tends to be far more fragmented. And results for pediatric patients have gone forward in leaps and bounds relative to what the improvement we've seen for adult patients. So we need care delivery that is clinically integrated and the services that are provided rather than fragmented. That's the fundamental puzzle. What Viv pointed out is the fundamental puzzle in healthcare. It's, why is it that the sector is so resistant to improvement in value? All these smart, hardworking, well-intended, well-trained people, and yet we see persistent problems in errors, in variance, in inconvenience, and we see costs, spending continuing to rise. So it values the change in the health outcomes for the money spent. And we need to be structured around how we improve health outcomes, and we need to have evidence-based medicine focused on those whole continuums of care. We're not going to get that improvement dynamic unless we do that kind of restructuring. So evidence-based medicine needs to reflect how value is created. The momentum now is around measuring patient satisfaction rather than measuring health outcomes. And Charlotte made a really important observation this morning when she pointed out that 91% of the spending increase in the recently published article was attributed to prices rather than to volume. If we measure patient satisfaction only, we put ourselves at risk for that because we'll get the increased expense of bigger TV screens or fluffier pillows without the added benefits of improving health outcomes in ways that reduce costs down the line by having people be less sick. Don't get me wrong, patient satisfaction is important. Everybody should be treated with dignity, but it should be the floor, not our grand ambition. And we should be measuring health outcomes in order to get this across journeys of care, across multidisciplinary teams, in order to get the structural change that we need. If you look at the improvements in cystic fibrosis, we looked at outcomes by integrated clinical teams in different places and then compared the processes and the activities that went into achieving those outcomes. We've had dramatic increase in life expectancy, average life expectancy for those patients, dramatic increase in the quality of life that they experience. But it comes from looking at the whole solution, not just looking at the parts.
Thank you, Elizabeth. I mean, I think that raises, you've very well, I think, set out the stall, what needs to be achieved. I think that raises two questions that I'm going to address, I think, to Peter and Bill. One is, I guess, what infrastructure, what do we need in place in order to achieve it? And the second question is, how then do you incentivize that sort of behavior and that sort of integrated? So I'll give an example from EIU Healthcare, where we developed a service specification back in the UK for payers there around complex services like cystic fibrosis and around cleft lip and palate, where it's integrated across the entire pathway. That was fine, but then what was needed was the data systems to be able to monitor the quality in a meaningful way, and then incentives to make all these different fragments of care join up. So maybe Peter, could you talk about maybe some of the incentives, and reimbursement is one, obviously.
Sure. So, as you said and Elizabeth said, we're seeing innovation across the evidence-based landscape broadly. And before I get to incentives, let me just say, part of the change we're seeing is in methods. So methods of searching, synthesizing evidence. Lots of innovation in the analytics, predictive modeling, and so forth. Lots of innovation around the data systems that I hope we talk more about. Not only producing data when there's payment and claims data as we used to, but now, of course, with electronic medical records, getting clinical detail we didn't have before. Lots of interesting innovation around getting information around symptoms and patient-reported outcomes and satisfaction and so forth. Third, new institutions. We have a patient-centered outcomes research institute at the federal level now. Lots of payers, both private and public, are developing groups to do analytics. All of that is driving innovation. The final piece, to get back to your question, is changing incentives. It's necessary but not sufficient to have innovation around the methods, the analytics, the data, the institutions. But to really drive behavior, we need to change incentives. And in a sense, while there are all kinds of challenges in doing the data and analytics, it's relatively easy relative to behavior change, which is hard. To drive behavior change, we need to change incentives. And that's the kinds of things we've been hearing this morning. ACOs, patient-centered homes, paying for value, giving patients incentives to use care, changing in the way Elizabeth talked about, the way we pay for bundles of care and so forth. So I think we'll see a lot of that, and I think ultimately that will change behavior.
And Bill, then how can providers adopt these, and what kind of data systems need to be in place? How data systems have typically evolved around billing. How do we make them? How do you transform them into something that's there for value?
Yeah, I'd like to pick up on what Elizabeth said earlier about how you define value when it comes to being able to measure what you get in terms of clinical response per dollar spent. And we really have not been in a position to be able to do that. The data that measures healthcare expense tends to sit in claims databases. So these are the data that the payer organizations have. And the level of detail there is very, very great. There's a great amount of granularity in terms of healthcare utilization and expenditures by procedure, by dates of service, and so forth. You can follow patients longitudinally in these data sets and so forth. But the measures of clinical response are very crude in those claims databases. You can measure things like whether there's a hospitalization. Sometimes if you have linked to mortality data, you can measure mortality as an outcome and so forth. On the other hand, clinical data that contains things like laboratory values and metastasis status and progression and things like that for patients with cancer, or Hamilton depression scores for patients with depression. Those data live at the provider sites. They live in the hospitals and in the physicians' offices. And they're not connected to one another. One of the things that I think is happening as a result of the Accountable Care Act is that with meaningful use of electronic medical records is that there's widespread adoption now of electronic medical records, which creates the technical capability to be able to link together claims data and electronic medical record data. And that's what we need in order to be able to measure value, because now we can start talking about the cost effectiveness, really, of different interventions. We're also helped along by technology where we now have methods that allow us to be able to encrypt data, create unique patient IDs at the source, pass those over a wall to a trusted third party, and link those patients together without ever having to identify who those patients are. So this allows us a HIPAA-compliant way to be able to bring those data together. And then lastly, I'd pick up on the point that Peter raised about the technologies. We have these very exotic sounding machine learning technologies, or recommender engines, the kinds of things that Amazon does when they see that you buy a particular book, random forests and vector support machines and so forth. But really what these are extremely sophisticated methods for predicting groups that look alike, groups of people that look alike. And this is a challenge that we have in medical research because, particularly for patients that are very complex in terms of their medical conditions, we'd love to be able to create groups of patients that look like that, to start with that as the beginning point, and then be able to apply our traditional evaluation techniques from health econometrics and epidemiology and health services research and so forth to be able to evaluate the very question, are we getting value for particular medical interventions?
I mean, I suppose there's the issue of, that raises one of the issues, one of the criticisms that's been kind of leveled, and it may be one of the reasons we haven't progressed as fast as we might like, is it's always post hoc. We always evaluate things in a post hoc way. How do we do this in a way that's in flight? That we're actually correcting course during a patient journey in the correct way rather than taking people to task after the event.
So Bill can talk more about how we cluster patients in medically meaningful ways. But one of the problems that we've introduced is we've kind of overcomplicated things. We can ask patients about functional outcomes and get very real data very quickly. You know how many days of work you've missed or whether your child was able to go to school. You know whether you can read, whether you can walk up the stairs, whether you can dress yourself. I mean, there are all kinds of important functional outcomes. They differ for different segments of patients, which ones are most important. But we can collect functional outcome data. When I work with groups of doctors, they often say, yeah, but I send out these forms to my patients and they don't send them back. And you ask, well, what do you ask? And if they're asking about waiting room time and stuff, patients probably won't send them back. But if they're asking about meaningful functional outcomes, quality of life, dignity of death, patients care about that and they will give that data back. And it's the outcome data from a patient's perspective is relatively simple. Can you read? Can you drive? Can you swallow? Can you talk? There are, some of them are really not tricky.
I mean, a lot of what we've been talking about has very profound implications for, I guess, every sector in the healthcare value chain. So, I mean, that'd be interesting to explore is let's say for the pharma industry, what does it mean when you've got an integrated, when value is, your product is one part of a big value chain, and we're actually trying to measure the outcome at the end of it. What does it mean in terms of R&D, and what does it mean in terms of how you're going to operate?
Well, I think it means, sort of fundamentally rethinking some of what we're doing. I mean, even when the evidence base is there, we often find that patients don't do what they're supposed to do and providers don't sort of do what they're supposed to do. For example, we know people with diabetes, just take as one example, it's hard to get a lot of people to stay on diets and exercise and stay with their drug regimens. And sometimes it's hard to get physicians to sort of follow up in ways that are appropriate. Why is that? It's probably challenging, multifactorial, but it's a systems problem in a sense. It's an infrastructure problem in a sense. And it's a, sort of a integrated system problem. So what do you do? Well, ideally, we'd like to put incentives in place to encourage people to do the right thing. So maybe we waive copays for people to take their medications. So a lot of interesting work going on with value-based insurance design, value-based benefit programs, where you waive copays for people who should be doing. Now, you need an evidence base in the first place, but then you need to overlay incentives on that. There are also some very interesting experiments going on with paying providers when their patients adhere to the medications. So if you begin to put incentives on top of evidence, behavior change is still hard, but we can begin to better integrate evidence into the systems and drive behavior.
Yeah, I would just pick up on that and say the generation of evidence is a necessary but by no means sufficient means to an end. That we have about a 17-year lag between the generation of evidence that something is effective and its actual incorporation into clinical practice. So how do we compress that time frame and get things into clinical practice more quickly? And I don't think technology is the complete answer, but it is part of the answer. So being able to take this evidence and embed it into tools that actually sit on the physician's desktop, so that when they have a patient in front of them that has a particular clinical profile, they can immediately pull up and say, here are the treatment alternatives, and here how patients did that were treated with treatment A versus treatment B. And so I think, and we're definitely moving in that direction in terms of the creation of these kinds of tools. It's a way to kind of hardwire the evidence directly into tools that the physician has immediate access to help them in their clinical decision making.
And we can go a level deeper, or maybe it's a level less deep, but in asking why it is that people adhere or don't adhere to the advice. And some of the work that Scott Wallace and I've done on restructuring, redesigning care, working with patients with diabetes, for example, when we ask people about what prevented them from adhering to the advice they were given, the most common answer we got from people was, I need to keep my job. What's going on there? What's going on there is that they're being advised to do a whole bunch of different appointments at different places on different days, and a whole bunch of errands they have to run in order to get the drugs and supplies. And to miss that much work, they'd lose their job. So if we think about clinically integrated care, if we think about making it convenient, I realize that sounds superficial, but it's not superficial if it's so inconvenient that you can't do it and keep your job. So if we think about from the patient's perspective, how do you make success possible? We can get a different level of engagement and adherence than if we just think about it with, are you following the advice? We need to go back and ask, what's in the way? And then redesign to get those things out of the way so that people can succeed.
I mean, I guess we'll move to questions shortly, but I want one more question, which is really around measurement, performance measurement. I think one of the perhaps perverse consequences of the adoption of evidence-based practices is the constant measurement of process in lieu of outcome, and which is not, and I suppose a flurry, an overwhelming flurry of things that we ought to be measuring. How do we pare that down to something that's manageable and meaningful? I mean, what are the examples of where you've seen that happen?
Well, I would just say that I think one of the reasons we've had such an overwhelming focus on process is because that's what we've been able to measure. And in claims data, for example, we have great great amount of detail on process. We see exactly what happened to this patient in terms of how they were treated and over what period of time and so forth. But we haven't had good measures on clinical outcomes themselves. And the clinical data are challenging because they've been incomplete. So a lot of the evidence actually lies in the physician notes, and even though we have structured fields that are supposed to capture things like blood pressure and body mass index and really some very basic things, often they're not even coded in any structured fields. They're in the physician notes. So there's a lot of work that needs to be done to create the data infrastructure, but that will help a great deal because then we'll actually be able to tie all those process-related things to what it actually generates in terms of clinical outcomes for the patient.
Yeah, could I just add, in addition, I agree with what Bill said. It's often challenging to get outcome data because they're long-term events. It may be very expensive to get them. We're certainly getting better, and Bill mentioned examples, but measuring outcomes has proven a challenge. Even when you can obtain those outcomes, we are almost invariably in non-randomized environments, as we say. So we then need to tie use of services to those outcomes compared to control groups where we don't have randomization. So there's still a whole series of challenges, even if we can measure well.
Yeah, thank you.
And when you think about those challenges, some of it is just stepping back and asking what's really important. So when we were working with MD Anderson on head and neck cancer, and they were tracking how long people lived. And what really makes a difference is the quality of life during the time that they're alive. And what they discovered was if you ask, can you swallow? This is after surgery for head and neck cancer. Can you swallow? Can you talk? It's not that hard to get data on that, but it's very, very meaningful about the quality of life. And it's relevant at the end of life as well. I mean, think about it. At the end of your life, you want to be able to tell your family, I love you. And if you can speak, you can do that. So, there are some simple measures that are highly meaningful and that we could be collecting, and we can drive improvement that way.
So I'll open up to the floor. I mean, are there any questions for our panelists? Yes, please. There's a microphone that will come over to you. If you just keep your hand up and then please say who you are and thank you.
Thank you. Hi, Kathleen Clawson with Roche Diagnostics Washington office, formerly with CMS and HCPA. I just have a question. What we're hearing from customers is that there is very much a difficulty with physicians actually changing behavior. For example, if you look at some of the screening provisions in the Affordable Care Act that are tied to guidelines, USPSTF or HRSA guidelines for cervical cancer, for example, the physicians don't want to change and extend intervals of testing. They want to do this annual exam with a PAP, no co-testing. There are innovative technologies out there, including some by Roche, that are, one of a kind in a market where you can get results for genotyping 16, 18 in one test, one payment, and it's not being utilized. Rather, what we're seeing is sticking to old behavior of the more you do, the more you're going to get paid. So let's do the old testing method and then go back and try to bill for more things. So what we're seeing is physician behavior can sometimes prevent some of the benefit of evidence-based medicine. I just wonder, maybe Dr. Newman.
Well, no, it's a very good question. And I said earlier, in a way, evidence, data, analytics is easy relative to behavior change. So part of the answer undoubtedly is better information education. And there's a lot of research that shows information education does have some impact. But we need to couple it with incentive change. And I think if you change the incentives, the way the information is used changes. So I think we need to somehow figure out not only to improve the evidence base and educate physicians and others for that matter. But we need to provide incentives for them to do things that are consistent with that evidence base.
Yeah, I agree with that. I'd just add that it's very interesting for folks that have been involved in establishing electronic medical record systems with physicians. When they get back their first reports on their patient, they say, oh, there must be a mistake. It's not, these are my patients. And so this idea, they have a particular, doctors often have a perception that there's a particular patient outcome associated with their care, with their treatment patterns, but they may be completely unaware really of what's actually happening. So I do think it's a two-pronged sort of thing. The evidence first, and then incentives second.
Any more questions? And I'd ask you just to keep the question fairly brief. We've got about a couple more minutes left, so thank you. Microphone. Oh, okay.
Deborah Prothorstedt from Spencer Stewart. Along those lines, the dissemination of evidence-based medicine, a lot of physicians practice what they were taught to practice, and I'm wondering if there are medical schools that are really on top of not only teaching evidence-based medicine, but being able to have students appreciate that the evidence will always be coming, that there's a maintenance of certification kind of issue. So I'm wondering if you've seen models of that incorporation into medical education.
Briefly, please. Thank you.
You're absolutely right. It's a great question because it's badly needed. A lot of the training that goes on at a lot of medical schools is with whoever's available in the community. So our up-and-coming doctors may be being trained by people who are getting below average results with their patients. There's a lot of discussion about it, a lot of attention to it. Do you know if there are particular schools that are doing?
I don't have any information. I mean, it's a great question, and perhaps there are schools out there that are leaders. I just don't know offhand.
Thank you. I think we'll wrap up now the session, but thank you very much. Thank you for joining us, and please give a warm round of applause to our panelists. Thank you very much. Thank you. Thank you.